Hello everyone! Today we're going to do back of the neck pain and dysfunction, so that's going to be great.
Here's just
Okay, so today the muscles we're going to be treating are the trapezius, the multifidi, the levator scapula, the splenius cervicis, the infraspinatus, the longus colli, and the supra and infrahyoids. So let's take a look at the pain patterns with those. Can you want to hold the camera for us here?
Sure.
Just 6 like that. So let's take a look at the pain patterns now.
Okay.
So these are all the muscles that refer pain to the back of the neck. So here's our trapezius, but here's the lower trapezius right here, and see how it causes pain all the way up here to the base of the skull, the back of the neck, and the top of the shoulder. So this is but look at where the trigger point is. It's way down low over here. So it causes referred pain up here. Now this top of the shoulder muscle, part of the trapezius, also causes pain right throughout the top of the shoulder and the back of the neck too. So trapezius is the most likely cause of back of the neck pain. The second most likely cause is the multifidi. So let's take a look at the multifidi over here. So here, do you think you can see it pretty good from there? Here's the multifidi. And you can see they attach onto the spine and then onto the transverse process there of the vertebrae. And these are the second most likely to cause neck pain. And so they can cause pain right there, a little circle right near where the muscle is. So this would be causing pain throughout this region here. Okay, so that's the second most likely. What's the third most likely?
Levator scapula.
Levator scapula. Okay, levator scapula. Okay, so let's take a look at the referred pain pattern for levator scapula. And it's a good one. Here it causes shoulder pain and neck pain. Here it is. So here's the levator scapula. And this is the Travell and Simons posters, and you could probably get them through Amazon. But there's levator scapula. You see it causes crook of the neck pain right there, back of the neck pain, and of course shoulder pain throughout here.
I think we have a newsletter on that too, right?
We do have a newsletter on that one. So that causes back of the neck pain. And the next most likely one is the splenius cervicis. Now this is remember we did this one for eye pain because it causes pain from the back of the head to the front, like severe eye pain right here. So here's the splenius. So here it is. So here where it attaches up here on the vertebrae here, and then again onto the vertebrae there. And it causes eye pain, but it also causes crooked neck pain, just like the levator scapula does, and just like the trapezius does. So you've got 3 muscles that cause pain pretty much in the same spot. So what if all of them are bothering you? Then it hurts pretty good.
Yeah.
Then it hurts real good. Okay, the next one here is the infraspinatus. Let's take a look at the referred pain pattern of that one. And the infraspinatus is interestingly enough, causes front of the shoulder pain, but in addition to that, it causes pain up here in the back of the neck. So it doesn't show it in this particular one here, but it does cause that. So the infraspinatus and the longus colli. Now that's one of the muscles that's very likely to cause pain in the back of the neck. And usually if you keep treating the muscles in the back of the neck and the pain never goes away, it could be longus colli. So
we worked on last week.
Yeah, we did work on that. We're going to do that again. So sometimes it wouldn't be uncommon for us to work on some of the same muscles 2 or 3 weeks in a row. So that if you miss it one week, you can, oh, how did she do that? Probably the next week I might still be doing that one. Because we do treat some of the same muscles each time for a couple in a row. Then we have the supra and infrahyoids. And they cause pain throughout the front of the neck and throughout the back of the neck. So they often cause you to be quite painful in those areas. So those are our muscles that we're treating today. So that's not so many. I think we can get through them all, right? Yeah.
Sure. Okay, this back of the neck pain. Then there are the nerve roots right next to the name of the muscle, and then the range of motion test right next to the nerve roots for that muscle as well. And here it is, number 10, the very back of the neck pain. Hopefully all of you have this chart printed out by now. It's an 11 by 17 piece of paper. It's going to cost you like pennies at Kinko's or FedEx or something to get this printed out.
This is on the website for everyone?
Yep. And then these are the protocols for how to treat each one of the muscles in this pain key. So this is pain key number 10, back of the neck, and then every muscle, the main muscles at least, that patients can treat themselves will be found in this protocol, and you can download and print these out for each person.
Yeah.
So the the general way of thinking is that when someone comes in, the first thing you'll want to do,
and then the stretches that they
and all the stretches, and what you do to make this personalized and custom is you just bring out your compliance tool.
And then usually what I do is I color in the muscle that we're going to be treating. So this is the first one we'll treat. And then I usually draw in.
Suddenly that muscle has appeared on the patient's body.
And then I usually show what tool we're going to use. So often I might use the back knobber, and then I go like this and draw it, and then I go, like that.
Yeah, exactly.
And then show them that they could use the back knobber on that one.
Mm-hmm.
Maybe I only give them one to do today, not the whole thing. And maybe next time when they come in, I'll give them levator.
Sharon, why don't you pretend the camera is someone who you just recommended that to, so they can see what it feels like to be the patient with you recommending this.
So, well, I start drawing the muscle, and then I see how easy it is for them to learn it. And if it seems a little difficult, then I might only give them the one muscle to do. But yeah, we'll be doing it shortly. Anyway.
All right.
Okay. Yes, we will.
So
at any rate, so then that's usually how I do it. And then this is 10, and this was from last time. This is 9. We did last time. This was front of the neck pain.
So
okay.
I want to show what the back knobbers look like.
Yeah, let's do it.
There
Let's
we go.
Here's the back. We'll do it.
So in general, Sharon has shared with me that her first, she said there's an end product to the evaluation, and that is a treatment plan. And one of the first things that she'll be thinking about, of course, is which pain key does this patient need to focus on first, right, Sharon?
Right.
So when they come in, you should be already thinking, what pain key am I looking at here? And then
usually what I do is I do a nice evaluation of them.
Mm-hmm.
But I'm looking at, they're going to draw their pain, so now I'm going to look at what pain key is similar to the pain that they have.
Yes.
And then we're going to look at all the range of motion muscle that they pass.
Do
And
we
then
have
the one
a symptom sheet for them to see as well?
Yeah,
Can you do one?
yeah, a symptom sheet that we always draw on.
We draw.
Yeah. Okay, so today we're going to start with measuring. Yeah. So we're going to measure today. So we're going to do a couple interesting measurements. So the first one we're going to do is rotation. So we're going to do that first. So if we can do that on you. Want to sit on my little chair here?
Camille's
Which
going
way
to
do
be
you
the
want me to
patient.
face?
Yeah.
Face
take
this
your
way.
Yeah, any way you want to do. Okay, so one way of measuring is to have your head over them, and you can see where their nose is. And now I'm going to watch her as she's rotating to the right. So go ahead and rotate all the way to the right.
Okay, now
Wow,
just
pretty
your neck,
good.
not your shoulder.
Yeah.
Yeah, keep my shoulder down.
Okay. All right, so it's just minus 30 degrees. So we just want to increase 30 degrees, so that's good. So let's go to the other side. So 30 degrees to the right. Good. Okay, and on this side, we've got 10, 20, 30 degrees also. So 30 degrees, right and left, so for rotation. And she's writing it down over here. So Stephanie was so she was going 30 degrees right there, so we'll write it in, and then later on you could write it in again after a couple sessions and see how far it's.
Now was that minus 30 degrees or was it?
Yeah, so we're looking for 30 degrees of improvement. Okay,
Right, so-
cervical flexion.
So some people might
You might go ahead and
circle
put that.
fail
Yeah.
and put minus 30 degrees like that. Okay?
Correct.
Okay.
Yeah, usually I put minus. Good point, Justin. Okay, the next one we're going to do is lateral flexion. So here we're going to go. So here we did rotation first. Now we're doing lateral flexion. So for this, we go ahead and put the goniometer. So sometimes we just used our fingers to measure, right?
Right.
And sometimes we used a measuring tape.
Right.
Today we're using a goniometer.
Okay.
So we're going to put the goniometer right here and kind of have a spot on her head. We're gonna look. So now put your ear to your right shoulder, and we'll just see how far she went. And so 90 degrees is full. So she's about 35 degrees. So it's minus 10, 20, 30, 40, 55 degrees. Okay, so let's go to the other side. Okay, we're going to put it about at the C7 there. And then we're going to look for a little spot on the head. Okay, ear to your left shoulder. They're pretty good at this, yeah. They're about to there. And so here we've got, again, so we're minus, you could put your head back up.
Thank you.
10, 20, 30, 40, 55, about 55, 57, so a little bit more than 55. 57 degrees on the left. Okay, great. So we could do a little improvement there, and then we're also going to check to see if your chin can you can test your. So if you can squeeze my finger with your chin, and she can do that. That's a pass on that. That's a pass. Now what if she couldn't do it? What if she could go, so don't go down? So that'd be -4 fingers, and then chin down a little more. That -3 fingers there. That'd be -2. And then this would be by -1, and chin squeeze my finger. Oh, that's 0, 0, 0. So that's pass.
Okay.
That's a
One
pass.
pass.
She's got one
I got
pass.
one pass.
It's
one
nice to write
pass.
the numbers down in terms of how much improvement you want. That's something.
Yeah, right. That's true. So we might have a goal of improving 20 degrees,
Mhm.
you know, but we don't necessarily need to but you know, it's just a measurement, and then we can see how much we improve. Yeah.
Yeah.
So I'm going to put this right at the ear, and then I'm going to notice how much how much she moves her nose. So here I'm going to do it on this side. Okay. So go ahead. I'm going to watch your nostril. So nostrils to the ceiling. Okay, pretty good. So so now we are minus 10, 20, 30, 47 degrees. 47 degrees. So we could improve that one. That one we could improve. Okay, so we got those. Now the next one we want to do is 12. So here 12. This is the scapula mouth wrap. So this is going to do you're going to do the infraspinatus. So let's have you stand up. Let's do this standing. So we're going to do, so here, this one here, we're going to measure, for this one we use the measuring tape. I have my trusty kitty cat.
Oh.
One of my students gave me this. Okay, so we're going to do, so what you do is you get your hand behind your head, just like this, and then you're going to go all around. You could turn your head towards your hand, and you're trying to get your fingers to the middle of your mouth. Okay, so here would be -1.5 inches there. So let's try it on the other side. -1.5 on the left, and let's do it on the right. And here, so you measure from the middle finger, and that's on the right. It's 2 inches.
Okay.
So that's the infraspinatus.
Okay, we keep-
Oh, she noticed that.
Oh yeah, that one hurt.
Oh, Justin's gonna do it. There. Okay, we're taking a picture of Justin. You're gonna show us?
Yeah. So just come around the back of the head, and then turn
Oh,
Yeah.
he can do it.
like that.
Yeah, that's it. That's
Right.
Yep.
And then
Now
this
come
would be
way.
a fail like this.
Yeah, that's
See?
fail.
That would be fun.
Well, that's a pass. Yeah.
And this is a
Yeah,
fail.
yeah.
Like that.
Yeah, coming to the center of the mouth is a pass. There. Great.
He's a pass. Yeah, look at you. Good for you, Justin. Good for you. You're a pass.
Okay, the next one we're going to do is hand to the shoulder blade. Now, this is nice if you can get it all the way up to the superior angle, but then you could measure from the middle finger to the superior angle. So, actually to the spine of the
I
scapula.
can't stay
I meant to
here
say.
too long.
Oh, okay, let me hurry. Oh, very good. This is good. So this is a low normal, but it's still very good. So we'll go to the spine of the scapula right there,
Mhm.
and that's 7 inches through the middle to the spine. There we go. Let's try it on the other side. Okay,
And-
that's on the right. Mine. Oh, this one's much better.
Of course, pain during any range of motion test is an indication of a problem.
Yeah. So
It only hurt in the arm.
yes, it does go to the arm. Okay, 5 inches on the left. Okay, so that's test number 13, and the last test is number 15. Okay. So we're gonna
Number
do this one.
15.
Okay, yeah, look at that one.
Oh, yeah.
Okay.
What's it? Tell us what that's called, Justin. What's 15 called?
Oh, 15. Arm abduction test.
Yeah. So you can see that how they set it up. So we're going to do an arm abduction test. So first part we're going to have is we're going to have the thumb up, put the arm to the side, and then let's go ahead and have you. I'm going to give you just a little bit of resistance. You're going to take it all the way up. So go up, 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 up to there. Good. Was that any painful?
No, no.
Okay. Now we're gonna put thumb down. Let's do the same thing. Up, 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 up. No, no pain.
No pain.
She did it. No pain.
So this
Pass.
is kind
I
of
get
like
to
a
It's a pass.
this is kind of like a strength and range of motion test.
No,
Yeah.
Right.
Thumb up is going to be the deltoid,
Yes. Okay. Up. Mhm.
and thumb down is going to isolate the fibers of the upper trapezius.
Okay. So this is why we got the 15 in here. Go ahead.
Mm-hmm.
Great. She does it.
By the way, when you isolate a muscle for any kind of a function test, what you want to do is you want to straighten the muscle fibers out. So normally with the arm twisted like this, the muscle fibers will be twisted like this in the trapezius. So if you turn the thumb in, then it straightens the fibers out, and that's why it'll isolate that muscle more during the function test.
Mhm.
So yeah,
Yeah. Very, very strong. Very good.
Good.
Excellent. Okay. So you paid. Good. Good.
Keep moving on.
Okay, so we're gonna do some treatment on these muscles. Okay,
Mhm.
so let's go ahead and let's treat the trapezius.
Okay.
So we're gonna start with the trapezius, and let's I'm gonna treat your trapezius, and while you're sitting.
and Sharon, we've been. I just wanted to remind you that we were talking about using, showing everyone about some of the language that we use. So, you know, again, if someone were to come in and this is a symptom sheet they would present to us, then they would draw a pain. So let's say they drew some pain in a question mark like pattern over the head, okay, on the side of the head, and they said, yeah, I get migraines. Then we would say, okay, well, great. Well, let's see. That looks like, or in the back of the neck here, pain key number 10. Look at the list of muscles that causes pain in the back of the neck. And we would show the patient this list of muscles and say, now let's take a look at the number 1, trapezius. That has a pain pattern that looks like this. Does your pain ever feel like this? And they say, yeah, in fact it does. And then you look at what they drew and compare it to there and say, okay, so you have one indicator that you might have trigger points in your upper trapezius. And then we'd say, now, what if we were to do a range of motion test to see if that muscle can pass its range of motion test? And we would take them over here and show them this cervical rotation test, and they don't pass that, and the lateral flexion, they don't pass that. And so now we have 2 indicators that we have trigger points in the upper trapezius. Now we only need one more indicator, and then we're absolutely sure, and that, of course, is palpation.
We're gonna feel the muscle.
We're going to feel the muscle.
We're gonna see what's going on with the muscle.
Trying to figure this thing out.
And so,
She's figuring her hair out here for a second.
This.
I
you
could
just
assist
thing.
you, possibly.
Can you help me with that?
Yeah, I'll give
I
you
don't
an
know how it
assistance.
works, yeah.
So usually, if you do it right, by the time you have shown them a picture of the referred pain pattern that looks like how they feel, you have done a range of motion test that shows that they can't do what normally should be done, and you have palpated and shown them that there's all sorts of tender spots in there, you can say, based on all the research done by the world's first astronaut, Dr. Simons, and in the first female president's physician to work in the White House, you look like you're suffering from myofascial pain and dysfunction. And the best part about it is that it's really fun and easy to treat, and you can do a lot of it yourself, right? And
So yes.
Yes.
So we're going to take a look at the trapezius. So here's that famous question mark pain pattern at the top of the trapezius, and this one here gives you to you like that. Now the trapezius, it laterally flexes the neck, it extends the neck, it rotates the neck, and it depresses the scapula, so down with the scapula, and elevates the scapula, and retracts the scapula. So it does all those things. So we want to make sure it can do all those things really good. So we're trying to get it to do all its jobs. It's very important that it does all its jobs. So here, we're going to take a look at but you know what? Why don't we do the lower trapezius first?
Why not?
Why not? Because why? Because it often activates the upper trapezius. So let's take a look at that. Let's go ahead and let's treat this lower trapezius on the stretch. And treat that first and take away the underlying perpetuating factor in the back of the neck pain right here.
Our trapezius on the stretch.
So go ahead. So you're going to put like this, okay? And then we're going to turn your head like this. We're going to do the left lower trapezius.
And it
so
works really well seated,
So
doesn't
here's
it?
our trapezius right here. So we're going to come right here, and we're going to go right there and treat her trapezius. So what do you think of that?
Is that your favorite position to treat the lower trapezius, Sharon?
Well, it's one of my. I often like to treat them side lying on the table, and that's a really great way, too. This is a really great way, and we're just gonna add a little more stretch there, okay?
That one I feel.
So remember, these go up. These here go up. So when you're pressing on it, you can see if you put it on a little stretch, you can feel. So when you're laying on the table, you can't do this as readily as you can when you're seated. You can see if what you're doing makes it stretch more.
Yeah.
Okay, let's give it a little stretch. Oh, I had the heat ready. So do you want to give us a little bit of one of those hot heat pads?
They're right outside the door.
That's another one, but I was going to use
Oh,
the.
you can use that one.
Okay, that's another one. Okay, so we'll put a little heat on this side after we treated it. We'll just use that one the way it is. Didn't I turn it on?
No.
Oh, it wasn't turned on. I was trying to turn it on. They weren't plugged in. That's right. Okay, heat in a minute.
Okay.
Okay, so we're gonna come over here. We're gonna look at the trapezius. Now I can feel the trapezius fibers right here. So I feel that they're not stretching right there. So I've got one finger on it here and one up there. So right now I'm gonna support her a little bit, and then I'm gonna come in here, and then come in right there, right on that lower trapezius, and do it while it's stretching. Oh yeah, there she's starting to stretch it.
Yep.
Good. Oh, that she's good at taking a treatment, right?
Woman versus pain. You can't fix it if you can't bear it.
That one doesn't sound
Mm-hmm. Okay, so, okay, good. So here I can feel some of the fibers are a little bit better. So let's see if they'll contract a little bit. I can feel they don't want to do their contraction. So I can feel here, see, it doesn't want to contract. And I can feel here, this doesn't want to contract. So let's take a look at this upper trapezius that doesn't want to contract. And let's see what we can do about that.
Okay.
So let's treat the top part. So let's start here at the bony part of the shoulder, at the acromion, and find your collarbone right there. Come just posterior to it. So you're going to just go ahead. Now it's nice to use your elbow. A lot of times the elbow feels better than the fingers because it's not as pointy, and it gives a lot of broader pressure. So it's a nice way to treat people. And then now I'm going to here. So when you first touch, so here, ooh, I
Very
got some
tight
hot
there.
bands right
Yes.
there. See, I'm flipping right
Yes.
over. I'm seeing it, Justin. So
Yep.
I'm palpating with my elbow.
Oh yeah.
And so I feel the top band. So I'm going to right on it. So I'm just going to breathe and relax. So you're going to press right on it. And you're looking for painful spots. What do you think? Is that a little bit painful?
Not too bad there.
So we're looking to press on the hard spots, the painful spots, and the spots when you press on them, you get really big increase in range of motion.
Yeah.
A little
Right.
bit medial, I know will be.
And you're looking for
Oh,
what
yeah,
eliminates
there's
their pain. Okay,
Yeah,
so here,
okay.
we're right on that little bit posterior to trigger point 1, and trapezius at trigger point 1, according to Travell and Simon, the founders of the field. So here we are. I'm just holding it. It's very painful, so I'm not pressing any harder. What do you think of the painfulness?
I feel it.
She notices it.
It's not horrible, but I
Yeah,
feel
so
it.
I'm holding it, and I'm seeing if I hold it a little longer, possibly, maybe it'll move.
Now it's a little more intense.
Okay. Okay, then we're going to come up slowly. So usually we touch, and then we go down slowly, kind of like a drill press, really down slowly. Now another way of treating this area here that we're going to treat is, so we really get the trapezius part, is we're going to do pincer compression. So there we did compression with the elbow. Now we're doing pincer compression with the fingers. So, so we're pincing. So we're also, again, we're putting in a slight stretch. Oh, and it moved there pretty good. That's pretty good. How's it doing it? Yeah. So we're doing kind of, before we're doing like pin and stretch. So we're pressing on a taut band, and then we were stretching at the same time. And here we're doing, we're pincing and stretching. Pincing, and we're looking at what's the improvement in the range of motion. You got one for us? Huh?
Yeah,
Got
that's
one
one
right
right
there. Okay. We'll just keep you a little warmer on one, a little bit while we're working.
Okay.
And sometimes we like to have people come in and do a heat sandwich before their treatment, right? So if they have time, maybe they can come in and use a little bit of heat in the waiting room or another room.
Yeah.
While they're waiting for their treatment. If they come in early, they could do that ahead of time. So they could have a little heat treatment before their treatment.
Yeah.
So now we're going to come up. No, the trapezius attaches onto the base of the skull.
Yep.
We're coming up. So we got the trapezius right here, and we're pincing it right there. Right there. Yeah, I feel how it's restricted right here. Mm-hmm.
Now there's one test that we didn't do,
Oh,
and
what
who?
did we do?
Uh,
Oh, wonderful.
But yes, the nerve roots. The nerve roots, of
Yes.
course. If a muscle's not responding that well to treatment,
We didn't do it.
you might have an irritated nerve root causing the entire distribution of that
Yes.
nerve
Yes.
to be irritated.
So that would be like you could look at it from the point of view of the myofascial trigger point therapist.
Mhm.
That's an underlying perpetuating factor.
Uh-huh.
But from the point of view of the chiropractor, it would be
The cause of all disease? Are you kidding me? It says on my psyche, baby. That's bread and butter right there.
Yeah.
and it would be a subluxation and all kinds of things. Yes,
Yeah,
yes,
yeah,
yes,
yeah,
yes, yes. So
Or you could treat them both and just be
yes,
a great
both.
body worker.
that's it. We could do everything. Yeah.
Yeah.
So we're gonna look at the nerve roots too.
Yes.
We are gonna do that. Yes,
Yeah.
we will do that.
Yeah, yeah, good.
We're gonna check a bunch of underlying perpetuating factors, including that. So here we're gonna take a look at the trapezius, and then again, so if it's not too painful, we're gonna move on to the next spot, and we're looking around. We got a taut band right there, and we're gonna come right here.
Okay, that's nice.
Now we got one right here. Okay, so there we go.
Mhm.
Breathing and relaxing. Good.
Well, and that's the trick to being a master body worker, is that you don't get discouraged. You know that every result is a clue. So if it's not responding quite yet, then why not put a little bit of stretch into maybe a little more stretch. Maybe if it's not the lateral flexion, how about try rotating when you work on it? Maybe it releases with rotation. Or maybe it's a nerve root that's irritating. So when you're a master body worker, you have plenty of things up your sleeve. You don't just give up or accept 10% improvement. You keep going until you've squeezed all the improvement you can out of that area.
My hair's fine.
Now I'm looking for 30 to 100% improvement per treatment. So like I'm looking to see if I can get about 30% improvement.
Yes.
So that's the ideal. So then if you're getting rid of a chronic problem, if you wanted to go away, it was going away really fast. It might
Sure.
take about a month.
Yeah.
Yeah. So a really bad chronic pain problem
Sure.
in the neck, if it was going away lightning fast,
Yeah.
would take treating it every day for about 3 weeks to a month.
Yeah.
Now, if it was average, probably it would take about 2.5 months, and if it was taking a long time, it might take up 3 months to 4. So
Oh, you meant acute by the first one?
well, it wouldn't.
An acute one would be about a month, you
Even
said?
no.
Oh, no.
Sometimes, yes. It could, what I did was I was talking all chronic.
Okay, correct.
Sometimes
sorry.
a chronic problem might go away in as a little bit over a month.
Mhm,
You know,
mhm.
if it was going really fast.
Yeah, yeah.
Really, really fast.
Okay, I see what
Yeah.
you're saying.
But an acute problem, it might go away from treating it once.
Yes.
But then you might want to keep treating it to make sure it doesn't come back.
Right.
But treating it once, it might go away. But you might have sometimes you have to treat things over and over and over again because
yeah.
it just won't go away. So, but until you treat it a lot of times, and finally it goes away. It's so wonderful.
Well, we talked about that when we in the newsletter on Franken neck syndrome, where the levator scap literally becomes almost frozen and you can't turn your head. Many people just deal with that and say that has to run its course, because they're not taking the time to go on the stretch and then all the way on the short, and then the stretch again, the short, lengthen, shorten, and if you just don't give up until you've got it working the way you want it to, that little bit of willpower will enable the muscle to surrender and for it to go away in one drink.
Blank muscle.
Okay. Name a muscle in the anterior neck that flexes the neck. Laterally flexes the neck, rotates the same side, and refers pain to the posterior neck.
Okay, the first question someone asked us to repeat it was, is this true or false? Trigger points in the anterior neck fascia can entrap the brachial plexus. Yes, and why would that be useful? It's true. Why would that be useful? Like what might a patient come in with if they had entrapment of the brachial plexus? Well, they could have all the kinds of things that they might think of as carpal tunnel syndrome. They might have any of the nerves that run down the arm. Those kinds of symptoms. Tarsal tunnel or what's that? Antecubital fossa entrapment one. There are muscles in the anterior neck that can entrap the brachial plexus and cause a lot of the things that people are, having surgeries for and things like that. Oh, cervical rib syndrome. Exactly. So.
Okay,
what
next
muscle is
we're going to treat the multifidi muscles. So here's a picture of the multifidis right here. They go all the way down to cover the sacrum and all the way up here. You can see they come up here to C2. So and then they attach on the transverse on the outside of the vertebrae. So that's what we're going to look at next. And they rotate and extend the neck. So we're going to look at those but what's interesting about the trapezius and these multifidis is the trapezius can compress the greater occipital nerve, and these multifidis can compress the nerves, all the C2, C3, C4, C5, C6, C7, like that. They can compress the nerves on the side where they're tight. So we're going to take a look and see if these muscles, so we're going to palpate them and look at them, and then we're going to also see if there's, we're going to look for heightened tone in the nerve roots. So let's take a look at it seated, and then we're going to take a look. So here's one picture of them. And then we have the referred pain is right where the muscle is in this case. So this is if it's dysfunctional here, it's here. If it's dysfunctional there, it's there. So it's along the whole spine, and it causes pain on the front of the chest and abdomen as well. Okay, so let's take a look. So let's so if you could, Justin, if you just take a look here. So we're going to see with her seated in her seated position. Is it easy for us to lift her skin up? No, it's not.
Right.
So we have heightened tone in C1 through T2, T3. Okay, so definitely we've got heightened tone in all of those muscles. So let's take a look at how we might be able to correct them. So let's feel them do their jobs. So they rotate and they extend. So let's feel what they're doing at all those levels. So I'm going to feel it rotating. And okay, so I can feel it's not doing its extend job. It's doing its stretch job, but it won't do its extend. So I'm checking it as I'm going down. So I'm doing compression with the shortening because it's dysfunctional on the short. So here, I'm doing compression on the short. Good. So let's take a look at the other side. And for this, I'm just going to put it on the stretch first. So I'm just going to go like this and put it on the stretch. So here's the spine of the spine. The spines of the spine sticking out here. And here's the transverse processes. And we're going to be working on this muscle. So they attach here and then go down here and attach there. They attach here, then come like this here. And if they press together, they can compress the nerve.
Yeah.
In there. So we're going to go ahead and treat that and see if we get, so we're going to this time I'm just going to treat it on the stretch. So I'm holding it while we're stretching it, and I'm going to rotate it and see if it increases rotation. Oh, it does. It's increasing rotation a lot. Wow, that's great. How's it feel when we're treating that?
I don't feel it at all.
Okay, so it's just, it's not painful, so it doesn't have painful chemicals in it, but by treating it, it's increasing the range of motion, so we're micro stretching it.
And you're educating it too.
Yeah, so we're micro stretching it. And it's really turning. Wow, she's getting a really good turn there. So let's treat the other side on the stretch, and then we'll treat both sides on the short as well. So let's go ahead and treat it on the stretch. So we're going to turn it this way, and we're going to feel. So I'm going to put it on. I'm going to hold my fingers on her cheekbone, and then I'm going to press on the muscle. And then while I'm pressing on it, I'm going to see if it increases. It does. It goes like bang. Can you see it?
Yeah.
She's just increasing range of motion just by pressing on the first one. And then come this way.
Yeah.
So it's coming right along.
Someone asked, can this be done in someone who has a pinched nerve? And,
Yes, this is how you get rid of a pinched nerve.
Yes.
Yes, this is how you do it.
Yeah.
Mhm.
And in the beginning, the range of motion may be really small if the
Oh, it
nerve
may
has been
be.
pinched.
Oh yes, it may be. They may be because of pain. They might be. The pinching may cause so much pain that you just could do it a little bit. Everything the same we're doing, but keeping in mind
Yeah.
not to make it too painful.
Yeah. And,
Okay,
and
so-
that's why she treats it on the lengthening, on the stretch, but also on the short.
So here we're going to do this the right side on the short now.
Yeah, let's do
So
the
here
short.
we did this. We did it on. So do it on this side. So we're going to right on the multifidi, and here we're stretching it. Now we're going to put it on the short, and then we feel it. This is what I do to myself every day in the shower. I get my tool right on the multifidi here, and look for tight spots and painful spots, and I get right on it, and I make sure that it does its full job. I should make it do its job.
Yeah.
Make it do its job.
So this, and that's why the muscle itself may have gotten used to only moving within 20 to 30% of its normal range of motion. So when we educate the muscle by taking it through its full range of motion, then we're teaching it. Also, the little nerves may think that once it gets to 50 degrees of rotation, that's it, and they start to send pain signals anything beyond 50 degrees. Well, that compression teaches the nerve, nope, you've got a lot more to go before I want you to start complaining. And so that's what we mean by re-educating the muscle to have full range of motion and full function, and then re-educating the nervous system to have different set points for thresholds of pain back to where we know that they are. And the more you work with muscles, the more you'll get this intuitive intelligence waking up within you to know, where the muscle should be, where its function should be. So Sharon
nice
is,
and warm.
yeah, Sharon has no lack of confidence knowing exactly how that muscle should be behaving, even when the patient has no idea that it was, what normal is. Sharon knows what normal is, and she helps the muscle remember what normal is.
Yes, but I remember the last several hundred I treated.
Yes. Experience
Okay.
doesn't hurt.
Why does Travell call the trapezius the coat hanger muscle? Okay, so we'll find out that. So that'll be good. And stiff neck syndrome is primarily due to trigger points in what 3 muscles? So those are a couple more of the questions. So it's in 3. So there we go. So the 3 muscles that's most likely to cause stiff neck would be who knows?
Or Franken neck syndrome.
Yes. So the 3 muscles that are most likely to cause stiff neck syndrome are splenius cervicis. So this muscle here that comes like this is one of the main head turning muscles.
Splenius cervicis.
Levators.
Can you show us where that one goes?
This one starts here, comes like this, and then attaches all the way up here. So splenius cervicis, and it's one of the main head turning muscles, and it causes really bad pain right here, and in the back of the neck here. So the splenius cervicis, the trapezius,
Yep.
and what other muscle do you think?
Levator
scapula.
That's the one I did.
Yeah, so levator scapula right here, so they all cause pain right here. So that's it. So it's stiff neck syndrome. Yeah, that's the.
So yes.
So the levator scapula. So one of the 3 muscles that cause stiff neck syndrome, right? So it attaches onto the scapula, and then it attaches onto the outside of the vertebrae right here. So we took a nice little picture of it here. We got it from Mosby. So here you can see it attaches onto a C1 to C4, and then onto the scapula, levator scapula, and it elevates the scapula. It extends the neck, and it laterally flexes the neck. So let's take a look at that. So we're going to take a look at the levator. So
Thank
it's
you,
right
everyone.
here.
We appreciate you guys very much.
So here it is. So we're going to put our elbow right on it, and we're going to put it right on a stretch like that. And so it extends back. So we're going to put it on a little anterior stretch.
Good spot.
And then we're going to take it up to the transverse processes of C1, 2, 3, and 4.
someone commented they're learning so much. Yeah, and we're really doing it at a pace where there's plenty of repetition. I know that, you know, in the beginning the mind says, oh, I know that already, but every single time you do it, you learn a little more.
Yes, every one of those were good spots.
Good, good. So you like that levator scapula?
Levator scap
that's
was a home
one of
run.
my muscles, yeah.
Okay, so here again, here's our levator, and we're going to go ahead and put it a little bit on the stretch. So we're going to go ahead and put our elbow onto it. Then we're going to take it through its different ranges of motion,
Okay.
and then treat it while we're going through a range of motion. So getting right onto it there.
Oh, yeah. Good spot.
Yeah. That treating on the stretch is just a miracle.
Well, what we're doing is lengthening it while we're lengthening it microscopic, like on the micro, and then we're also treating macro at the same time. So we're putting it on a full stretch. So we're macro stretching at the same time where we're micro stretching. Yeah.
Yeah, the compression is like a micro stretch on the little taut band of muscle. Those little taut bands of muscle don't coincide with the length of the whole muscle.
So here we're going to put the levator. So let's bring the shoulder up towards your ear. So let's really put it on the short, and let's really put it on let's get it, pull it apart. Okay, let's push it together and pull it apart.
Yeah.
And let's push it together and pull it apart. So this one, I never am done with this one till I can really shorten it.
Yep, she
I gotta
doesn't
feel
leave it alone.
So you
She
should
doesn't
shorten it.
Yes.
It's got to be able to shorten that one.
My wife was treated by Sharon, and her experience was that Sharon just doesn't stop until she gets what she wants out of the muscle, and that the muscle finally realizes resistance is futile.
Okay, let's bring that ear towards. So let's bring it together, and let's take it apart, and let's bring it together, and take it apart, and together, and apart, together, and apart. Good. And let's rotate, and rotate this way. I really feel the contribution of this particular muscle to the rotation.
Right.
I feel, what's this one doing? This particular muscle.
Look at that full rotation she's getting. It's amazing.
Let's take a look on the other side.
And she's not doing anything with the neck that isn't natural for the neck to do on its own. So, you know, it's a wonderful technique, in that, you know, there's no harm that you have to worry about doing if you're just asking the neck to do what it naturally does. You know.
Oh, it feels a little better.
Yeah.
That's feeling a little softer.
Yeah.
And
Okay,
and remember the nerve roots, how you know, bad the nerve roots were. You could be battling the muscle a really long time if the nerve roots are causing them to immediately reactivate. So it's a very good idea to treat the nerve roots when it's as bad as this was, to get those first even.
Next, we're going to, let's see, the splenius cervix is the next one.
Nice.
So the splenius cervix, you can see, it starts over here on the spine, the spines of the spine there. Okay, so it starts there, and that's T3, 4, 5, and 6, and then it comes up and attaches up here on the wings of the spine at the C1, 2, and 3.
Yeah.
So, but we're going to put it on a really big stretch. So we're going to turn. This is the most likely one to cause stiff neck. This one here. This is really, really common. And remember, it causes really bad pain right here at the crook, and it causes pain as it's getting worse from the back of the eye to the front of the eye, coming out like a poker.
Mm-hmm.
So this is one that causes a lot of headache. Okay, so here.
So let's see, that was
That's
on
you
here,
wanna look at
number 4, most likely to cause
fourth
pain.
most
right
likely. And let's look at the pain pattern up there again. So there it is. And there it causes crook of the neck pain right there. And it goes from the back of the head to the front, causing eye pain. And it can sometimes, I notice, activate due to stress from eye stress, from keep looking at bright light while you're driving and things like that.
And not sleeping enough.
Mm-hmm.
Yep.
Okay, so let's go down here to where it attaches, Then we're going to get right onto it so you can feel where it's attaching. So T1, 2, 3, 4. So,
Are you to the
so
right
here.
or to the left of the spine on this one?
We're going to be just to the, so we're going to put it on the stretch. So to put it on the stretch, we're going to turn the head this way. So we're putting this part on the stretch. We're turning the head that way. You can
Right.
see that it's attaching here and attaching there. And while it's stretched, we're going to treat it. So we're coming this way. So let's come on down this way.
So she's using her left hand to give a macro stretch, and she's using her right
So 1,
hand
2, 3, 4, 5, 6, come
to
down.
compress and give a micro stretch.
Right. So here, and then I'm sort of giving her a little support there. So here we're turning.
Mm-hmm.
So I didn't feel anything here. But what did you think?
A little bit lower.
A little bit lower there.
Right.
Okay, right there.
Yeah,
Okay, yeah, right there.
That's it.
That's it. Okay. So she feels. Yeah, I can feel it there. Okay, we're holding it. So I'm right on a taut band.
Yes.
And we're pressing on it and holding it, breathing and relaxing. She's doing it.
It never hurts to laugh.
And use the smile muscle.
Yeah.
Whee!
Whee!
This is so much fun.
And come up all the way to transverse of C, 3, 4, 2, and 1. All the way over here. Okay, let's take it through shortening. Let's shorten it all the way. Let's really shorten it. I feel, does it do its job?
Wow.
Is it doing its job?
Mm-hmm.
And let's take it back this way. And let's feel, is it doing its job? And take it back this way. I'm just going through all the fibers, looking at some fibers that aren't doing their job. Okay, great. Getting pretty good range of motion there.
We're getting pretty good range
That's
of
it.
motion.
That's our head turning muscle.
Okay, let's finish the splenius surfaces, then we can take a break.
All right.
Okay.
All right.
Okay? Okay.
Okay. All right. So here's our splenius. So again, we're going to start. Here's 7. So T1, 2, 3, 4, 5, 6 comes down here, and it's going to be really close to the spine. But we're going to look for fibers that are sticking out, especially when you put it on an acute stretch with the chin a little bit flexed.
Okay.
So let's go ahead. Oh, what'd you notice there?
No, I just lowered my shoulders.
Oh, okay. Good.
They were up.
Okay, so
That's
we're
a
going
good
to come
spot.
up. Mm-hmm.
That's a good spot.
Come on up. So we're looking for painful spots here, so I'm just going to reposition myself a little bit. Okay, so here, I'm going to come this way. So I'm on the left side. And we're going to come all the way up. Okay, we're going to come to the transverse processes and see 1, 2, 3, 4. Good. So we're moving.
Yeah, good.
So the advantage of doing this while you're stretching is you can see, am I improving the range of motion? You can see, and if you are, then you know you're doing something good.
Mm-hmm.
Even if you don't know if they're going to be all better with their referred pain to the back of the neck, but you already know, oh, they sure can do that range of motion.
Yeah, that's right.
So that's really good. So we're going to just take a look just a little bit more at that range of motion. Let's push your head forward, push forward, and relax. And forward, and
So
relax.
it'll
Good.
contract and relax,
Yeah.
for those of you who know.
Mm-hmm. And push forward, and relax. And push forward. Good.
That's running on the right side.
Uh-huh.
I'm gonna do that.
Okay, so we have a few more muscles we're going to treat, but we're going to do that in a minute. So
Okay.
after our break.
Yeah, so just like there are 3 kinds of assessments, we're looking at a referred pain pattern, we're looking at range of motion, and we're looking at palpation. Then you can also see 3 types of improvement. You could see the referred pain lessen, you could see pain reduce, you could also see range of motion increase, and you could also see palpation
Scoot forward.
be less painful. And sometimes people will accuse you of pushing lighter. Oh, well, you were pushing harder before. And that's when Sharon usually pulls out the pressure algometer and says, no, you could only tolerate 3 pounds of pressure 5 minutes ago, and now we've just worked on it, and look, you can handle 8 pounds of pressure. That's a much better improvement.
Yeah, the
So.
pressure algometer is in the back of the car.
Oh, well. Don't ask her why it's in the back of the car. It has nothing to do with treating people in case they get in car accidents or anything like that.
Let's see how.
It should be.
The
Okay.
next muscle we're going to treat is the infraspinatus.
All right, so
Okay.
we've got a couple more muscles to treat, then we're going to look at
Yeah.
perpetuating factors.
Yes. So
All
this
right.
is the infraspinatus, and it attaches onto the whole back of the scapula and the shoulder blade, attaches onto the humerus, and its action is it laterally rotates the arm. So let's do it. So it's like this is. Let's do it together. So it'll be lateral. The thumbs out is its contraction.
Mhm.
Thumbs in is its stretch. Thumbs out.
Mm-hmm.
Thumbs in. So that's, but also that's its stretch. That's its contraction. It's kind of like a fan. So it moves in all these different directions like this.
Mm-hmm.
And remember the range of motion test was, can we get our hand to our shoulder blade,
Mm-hmm.
and can we get our hand around to our mouth, to the center of our mouth. So but what's interesting about it is it causes bad front of the shoulder pain, and it causes pain in the back of the neck.
Mm-hmm.
So it's an interesting So let's look at the pain pattern. So see, it causes pain here at the back of the neck.
Mm-hmm.
If it's almost always you see it, feel it in the back of the shoulder or outside back, and then you feel it at the base of the skull, right, or the base of the neck skull area there.
Mm-hmm.
But it also causes pain down into the hand and in the shoulder blade area.
Oh, definitely.
Yeah.
People that have like a tight pulling or numbness feeling in the hand oftentimes have infraspinatus pain.
Okay, so we're going to take a look at her infraspinatus. So she put a little heat on it. She was warming it up. So we're going to take a look at its range of motion. So here, remember, it's from the spine of the scapula to the so that's like like about 8 inches or 7 inches or so. So let's see if we can improve it. So we're going to treat the infraspinatus. So here's the spine of the scapula, and we're going to go just below it here into the infraspinatus. So we're going to treat it while we're moving it. So let's go ahead and first we'll give it a stretch. We'll treat it while we're stretching it. So this is so here we're pressing and looking, treating and analyzing, looking at, do we have any taut bands? So here, I didn't see, but here, let's see, right there. Okay, so here we have a taut band, so we're going to hold it.
Okay.
Breathe and relax. So we looked around on the muscle, didn't see a taut band up a little higher, but there we saw it. So we're holding it, breathing, and relaxing.
Okay.
And we're stretching it while we're pressing on it. How's that feel right there?
That's right.
Okay, now we're coming a little bit lower down here, so we're looking. How's that feel right there?
That's tight.
Yeah, so that's a little taut band right here. So we're stretching it. You hold it right there. Yep. So we're going to get right onto it and press on it. Wow. Now remember, this causes front of the shoulder pain down the arm into the fingers, and it causes pain at the back of the neck.
Mm-hmm.
Interesting?
Definitely.
That's a good one there.
Okay, so we're going to hold that one. And let's stretch it while we're pressing on it.
Oftentimes when you
Yeah,
push on these trigger points, people will feel pain down their arms and into their hand.
Mm-hmm. You often do.
Yeah.
You often feel, so if it's not an active trigger point that's causing pain all the time or a lot of the time, it may be a latent trigger point where it only bothers you. It causes shortening and range of motion problems, but it doesn't hurt unless you press on it. And then when you press on it, you might feel the referred pain pattern.
Mm-hmm.
Okay, so did you feel any of those referred pain patterns?
No.
No referred pain patterns. Good. So let's take it through its range of motion. Let's rotate in and let's rotate out. Rotate in and rotate out. Let's feel it's doing its job. Oh, I can feel we got some problems there. Oh, we got a few problems there. So some of the muscles don't want to do their job. So some fibers here don't want to contract, but also an underlying perpetuating factor in this muscle moving is the pec muscle.
Ah.
So the pec muscle's a little tight there. I just felt that.
Yes, they're tight.
And so that's what we highlighted things that were underlying perpetuating factors for her, and one of them is tight pecs. So so that's one of the ones. So let's take it through its range. Let's see if we can get it to do its job better. So here, oh yeah, so it's coming a little bit closer. So before is about inch, so it's about an inch better. So I just keep looking at so often I try to get it to pass the range of motion test. So I put it in this position. So one good stretch was taking it across like this. Another good stretch is taking it into this position. And let's treat the top fibers. So now we got them on the stretch, and now I'm going to look and see if there's any taut bands that you can find. She says yes.
There's a little bit there.
Yeah.
Okay, did you guys catch that? So, different ways to put the muscle on the stretch. Most people just treat the infraspinatus lying, prone on the table. But here she's got it wrapped all the way around the front of the chest and wrapped all the way back up to the shoulder blade behind the,
Now let's also get this section, especially on the stretch. And then we're going to take this around, and let's go to just try to touch the corner of your mouth.
Okay,
And let's do that. And let's also treat while we're doing that and see if we can't get it to go a little bit more closer to the corner of your mouth.
There you go.
Or to the middle of your mouth. Right there, yeah.
Excellent. Getting lots of hearts for this. Yeah, three different ways to put the infraspinatus on the stretch while you're treating it.
So push your elbow, push, and then relax, and push. Good. Okay, so we're going to go ahead and treat right here.
Yes.
So I can feel some taut bands right there.
I feel that too.
Yeah. So I'm just treating them on the stretch. What color were the hearts?
Well, we just had a yellowish, orangish one. We had some purple, we had some reds now coming in.
Yes, right there.
Right there. Okay, let's take it back through the range of motion. Let's see, are we doing a little better? Okay, so press down.
Sorry.
And push down. Keep pushing. Great. Okay, let's take it this way. Okay, great. Okay, push. Keep pushing. Yep, keep pushing. Get good. Push down. Push. Good. So we're gonna go ahead, push. Great. Okay, so we're gonna take it back this way. Okay, let's push outward. Out, push. Good. Okay, so how's that feel on this side?
I don't know.
Anyway.
Only when you
It
touch
only hurts when we touch it.
Only
Okay,
when you touch it.
So now we'll know if we're getting a little better if we see we improved our range of motion. So we're gonna put a little heat on this side, and we're gonna treat the other side. Okay? Put a little heat on this side. Then we're gonna treat the other side. So we're gonna treat it with the arm across the chest.
Okay. Yep.
So we're gonna go ahead and put the arm across. So this is one stretch. This is a stretch for the middle part. So let's look for some taut bands in there. Okay, I'm just gonna hold on to you here.
Okay. That's a spot.
So I was in Hawaii, and I was treating some people with shoulder pain, and they had pain for the one said 7 years, and while they were hulaing, while they were doing the hula. Okay, so there she's doing it for us. So while we were doing the hula, I treated their shoulder pain, kind of like this, and then pretty soon
I
they
should
were.
have brought my Hawaii picture. When I was there in '93. Okay.
So and then when I got through, there was yelling. They were going, "Oh my gosh, my shoulder pain's gone! It's been there for 7 years." and they were really excited. How do people in Hawaii get shoulder pain? They fall off their horse.
Of course.
Or they get slammed down by a wave.
Yeah.
That's how people get problems in Hawaii. Yeah. Okay, so
Oh,
here-
those kind of horses.
Yeah.
Riding the wild ponies, man.
That's it. So here we are. We're seeing if we can get this to come up a little higher.
Yeah.
So we are getting it to come up a little higher. So as we're treating it, so it's coming up a little higher. So we're looking for some taut bands.
Yeah.
And see, does it go up a little higher? So each time we're looking, see, does it go up a little higher?
Yep.
Then we're also going to look at the lower section here, put it on a little stretch. We're going to come around, and we're going to look for some taut bands here too.
Mm-hmm.
So let's go ahead. So here we put some fibers on the stretch. Oh, you can feel them.
Yes,
Oh,
yes,
they're
yes.
jumping. Those little fibers are jumping there. So we got those. We're looking at them.
Yep.
Oh yeah.
So again, the macro stretch and the micro stretch, using range of motion and compression at the same time.
Now, if you're doing macro stretching like you would say yoga, and if you have taut bands like these here, everything stretches but the taut bands. So then that's why sometimes we could be doing, we might even be a yoga instructor and do a lot of stretching, but still have a significant amount of pain because the muscles causing the pain might not be stretching. And this is how we get them to stretch.
Did you guys understand that? So we oftentimes will have a TheraBand, and I guess we don't have one on us right now, but it'll have a knot in it.
Oh, yeah,
And
okay.
and if you pull on one end of the TheraBand and the other at the same time, you'll see that the knot doesn't stretch, but the rest of the TheraBand does. So that's like the trigger point. The part of the muscle that has a trigger point in it, even when you're doing a great stretch, a great yoga pose or something, it may not stretch that knotted area of the muscle. That part may stay tight, and that's why you need the micro compression, the micro stretch, which is the compression. So when you find someone who's extraordinarily flexible,
Yeah, that's right.
does that necessarily guarantee that they're stretching every part of the muscle? No. It may look like they are on the macro level, but on the micro level there still may be, even in someone who's hypermobile, there still may be taut bands of muscle that have never stretched in a very long time.
Next, we're going to take a look at the longus colli.
All right.
Okay, the longus colli, we have some nice pictures of it.
Not to be confused with E. coli.
No.
No, we don't.
We don't want that.
We don't like that. No. So here is our longus colli muscle.
Okay.
And then here, you see the blue is all the vertebrae that it's attached to. So it goes all the way down to T3 and all the way up to C1. So it attaches on all these. And see, it's little fibers attached from one vertebrae to the other. And this is the front of the neck, you see?
Yeah, if you're seeing vertebral discs, that means you're seeing the front of
The front of the neck. So sometimes when they press together, they can make the disc squish out this way. So it could make, also it causes that back of the neck pain. So it causes also ear pain and eye pain. Isn't it amazing? Crazy muscle.
Yeah.
So it causes really bad pain in the back of the neck. It causes really bad ear pain and really bad eye pain.
Yeah.
And so it's
And they're implicated in many, many cases of cervical disc problems.
oh yes, that's true. Yes, yeah. Okay, so it flexes the neck and laterally flexes the neck. So this is its job. So here, we'll put this down for a minute. Okay, so here's it's doing its job. So we're doing it standing. So we're checking her out standing. And so here, so we're just looking at the longus colli muscles. So how do we find them? So we'll find the esophagus here, the throat, and let's just go right where the esophagus, and then you're going to go right behind it, and then you're going to flex. You're going to feel it doing its shortening job, and then back and feel its stretch job. So here, shortening and flex, and shortening and flex, and shortening and flex. Let's take a look at the. Hang on to this girl.
Hang on to something.
Hang on to this girl right here. I've got her. I got her
Okay.
good. Okay, so here again. So remember, you saw it. It goes all the way up here to C1. And remember, this is its job. So I'm gonna make it do its job. And ooh, I can feel it doesn't want to do its job
That's
on this
too
side.
deep. That's too deep.
Yeah. But see, it didn't like it over here.
Mm-hmm.
Yeah, there it goes. There, you know, she notices it a lot there. Yeah, so I found one part that doesn't want to work.
Well, what kind of injury may hurt the longus colli a lot?
Could be what kind of injuries? Whiplash.
I've had 6
She's had
whiplashes.
six whiplashes.
So
yes.
that could be the precipitating factor in her neck pain and dysfunction. Six whiplashes. 6. So if you have 6 whiplashes, how much does it take to? How long will it take to fix it?
You know, the thing is, muscles have memory, But that oftentimes makes people think that it'll take a long time to forget the whiplashes.
But may not.
It may not at all.
May not.
Injury recall can be eliminated. They've shown it neurologically instantaneously. You can get a muscle to reset to its normal pattern of behavior instantly. But you have to be able to go into that area of, if it's a longus coli, you have to be able to palpate the entire length of that longus coli along the entire anterior spine.
So another one that causes really bad back of the neck pain and front of the neck pain, we've been treating them, is your supra and infrahyoids. We did look at those quite a bit, but let's take a look at some of them. Here's some great pictures of the longus coli. Over a human, and they put a skeleton on it.
Oh, they do it just like we
So,
do.
There's some other nice longus coli pictures. Next, we're going to look at the supra and infrahyoids. So here's all of them, and each one separately. Here's the mylohyoid. This moves the tongue around and elevates the hyoid. Another one, this is a glenohyoid, and it elevates the hyoid, depresses the mandible, both of them do, the jawbone. And then some of the other, so basically what they do is they attach onto the hyoid bone, and they either hold it up or they hold it down, but they also cause really bad pain in the ear, in the eye, and also behind and around the whole neck.
Yeah.
Now, I would say that you have significant dysfunction with these. Okay, so
Thank you.
So remember we did the test of the chin going up, and also when I feel them, I can feel that they really do. And she said, "What did you say when I started treating them? What did you say?"
I forgot.
Oh well, she said.
I don't like it. That's for sure.
She doesn't like it.
I don't like it.
Okay, so here we're going to treat them. We're going to do a little bit with range of motion. It's significantly dysfunctional. Okay, so let's see if we can do something that makes it not as painful.
Okay.
Let's go ahead and let's chin down and let's chin up. What do you think of that?
I don't like it.
She doesn't like it.
By the
Remember,
way-
this is a significant cause of neck pain.
By the way, these cards, they're not in production anymore, but you might be able to find them used. Copyright 2005 by Mosby Inc., M-O-S-B-Y.
You can find them.
Yeah, you can probably find some. But,
I like those cards a lot, and I did get them used through, I think, the Amazon.
so Sharon didn't buy them new either.
Yes. So here we get some significant dysfunction in these. So when we treated these before, how did they feel when you treated them?
I didn't find any problems when I tried it. I guess I didn't squeeze hard.
So she didn't notice any problems with them.
No.
Come over here, Stephanie, and just feel. But you could just feel. So feel. Just go ahead and give a little squeeze. Don't squeeze too hard.
Oh.
Yeah, she noticed it right away. Yeah. So this is a significant dysfunction.
See, when
that
she
you have.
does it, I don't feel it at all.
Yeah.
So
Well,
I didn't squeeze hard enough, I
Yeah.
guess, when I did it.
Yeah. So this is really significant. Yeah. So this would be helping you with a lot of your back of the neck pain.
Okay.
Would be if we treated this, and it's not that hard to do, you know.
No.
But it needs to be done. Yeah. Now you can have me do it for you, or you could learn to do it.
I can do it.
Okay, let's go ahead and let's have you try it. So you're gonna see so you're grabbing onto it, and then you're gonna go really stretch and then really short, and then really stretch and then really short, and then really stretch and then really short. Yeah. What do you think? Can you do it?
Yes. It doesn't feel good, that's
So
for sure.
we're gonna make a more feel good thing.
It does not feel good at all.
We're gonna put a little heat right.
Camille's keeping it real.
Yeah, there we get it. Warm it up a little bit. Okay, so we treated the trapezius, the most likely, the multifidus, second most likely, levator, splenius cervicis, infraspinatus, longus coli, and the supra and infrahyoids.
Yep.
And all of that causes back of the neck pain. Back of the neck pain.
But think about it. That's all of that causes the back of the neck pain, but that's it. So if you watch this and you master this, you are going to be one of the best people at treating the back of the neck pain of just about any kind of practice. And I can say that because I owned an integrative medical center, and we had everything from acupuncture to nutrition to physical therapy to modified trigger point therapy and chiropractic. But this you know, when you say what causes neck pain, just like almost every other part of the body, it's muscles.
That's right.
And if you can treat those muscles, you are way ahead of the curve. You're in the elite top 10% of people treating neck pain.
Now, these are some of the underlying perpetuating factors in neck pain.
Now we have three classes dedicated to underlying perpetuating factors.
But we highlighted the ones that you thought were probably some of the things that were bothering you.
Right.
So Camille, these are the ones. So the ones she highlighted with first metatarsal deficit. So
she didn't circle severe character flaws.
We're trying not to mention that.
I see. All right.
She notices poor posture when sleeping.
Okay.
She's noticing the head forward. Also, leveling, like when she doesn't have her shoe inserts in, one shoulder is much lower than the other, considerably. So that's an important factor for her. Short pectoralis muscles, and possibly there might be a way that she somehow puts tension into her neck, in some way, maybe thinking a certain way, or working or something she's doing. Computer might do it. So different things she might do might put tension into her neck. So we're going to check. We're going to show first metatarsal deficit and what it's doing to her neck. Okay.
Wow, we're going to do that today. This is a big subject. We're going to cover it in much greater detail. In fact, the first metatarsal deficit is a whole class coming up
that's
several weeks away. But
okay, so here she has her shoes on, and her shoes have a correction and has a 9 millimeter lift in it in her under her great toe. So let's take this off for just a second. So so right now, if you take a look at her, you'll see that if you look at the spines of her scapula and then you bring your fingers together, you'll see that her shoulders are even. You can feel that they're even. Now we can then go and take a look at her hips. Wait, we'll do that in a second. And we'll look at her hips, and then we'll look at the posterior superior iliac spines, and we go, oh, I can see they're even. Okay, so that's great. You could also look at her spine and see how straight it is, and go, oh, it's pretty straight. Okay, so now let's take off. She has a shoe. The first metatarsal lifts in. We're going to take them off, and now we're going to take a look at it again. So this is the reason we put them in. Is now if we look at the spine of the scapula and come to where you can see that. And let me do it this way, okay? And you can see that this one is higher than that one now. So one shoulder is higher. This one's higher. This one's lower. So this is how I mark it down. So I'm going to show that to everyone. So here, I marked down that the hips were even because I checked the hips, they were even. So you can't put a heel lift in because then it would make her hips uneven. But the shoulders are like this. So we put a 9 millimeter lift under her first toe, and then look at this. Her shoulders and hips were even. She was even when we were seated, and so this is the first metatarsal lift that was correcting this. So so here we are. So let's we'll put on the shoes again, and then we'll see how it corrects it again. Isn't it great? So the side that's high will always have a lot of tension in it. So now we put it in, and you can see you put it in that little fossa or the supraspinatus fossa, and you can see, oh, and she's very strong because she's really, really, really strong and really stable. So it's like a little tripod. So the first metatarsal lifts make it a little tripod, and it makes her really stable. So did you have something you want to show, Justin?
yeah, if you guys need another plug for the what does the lift look like? Oh, we need to show what the lift looks like. In fact, there's a picture right here. It looks like it goes into the bottom of the shoe, and right where that red outline is, there is a lift that just lifts the first ray. Everybody know that expression, the first ray? When you go to toe off, Sharon, show us toe off. When you're about to go toe off, yeah, like that. The weight should go through the first ray, and in someone whose first toe is has a deficit, in other words, it's shorter than the second toe, as in the case here, where you can see that the second toe sticks out longer than the first toe. This person, in order to get over that extra ledge sticking out on the second toe, has to roll in and hyperpronate. And that's where you get hyperpronation during walking. And sometimes, occasionally, the person will be a bracer, and they will yank outward on all the external rotators and things of the hip and stuff, and keep themselves supinated, but they'll develop trigger points all on the lateral side, and this person will develop a whole bunch of problems from the hyperpronation, all because they have to get over this obnoxious second toe that's sticking out. And this is very common genetic, it's probably one of the most common genetic malformations.
So here's a correction.
Yep.
So the one that we have in Camille is 9 millimeters correction, so you can see it's pretty thick.
Yep.
And then this is 6 millimeters. That's very common. Often we put in 3 millimeters. So you can see that this would, and then the rest of it's nice and soft and flexible, but you see that it adds a dimension right here. And you could put this in also with your orthotics.
Yeah.
So you have orthotics as well.
Which I have.
You can
It's
use them.
overlooked in orthotics all the
Yeah,
time as the first
this is-
metatarsal deficit.
Yeah, so frequently you have very good orthotics, but they won't have the first metatarsal deficit correction.
Yep.
And this would be a good thing to add to it.
Yeah. So yes, the link that we're talking about is the metatarsal right here. Now the phalanges may vary or something, but it's very common also to have a deeper groove in between the first toe, and you see how the second toe, the skin between the second and third toe is not as deep as the first one. That's shown right here. See, it's deeper here than it is right there. And when you have that long second toe, this is a pressure plate analysis at the bottom of the foot. This is what happens is that the heel and the second toe, in fact, at times you get a callus under the metatarsal head of the second toe, they will form kind of like a skater's ice skate blade that causes the ankle to want to roll left and right instead of a tripod, which would not roll to the left or the right, wouldn't go in, wouldn't fall in, and it wouldn't brace outward. And so this is just by putting a little lift under the first toe, we can shift the pressure plate to this configuration and have a stable tripod to stand on.
But what's good about it for neck pain is that when it corrects the shoulders and makes them even, then you get your shoulders, you've corrected a really good underlying perpetuating factor. You'll also go back farther. You also extend back because the metatarsal lift will make you go back just a hair, and it'll cause you to be even, which is there's a big underlying perpetuating factor.
And just think about how many trigger
Unevenness.
points you could develop in all areas of your body if you were standing on an ice skate, with that wasn't tied very tightly and it was wobbling all day long. I mean, you develop them all throughout your legs, your knees, your hips, a lot of stuff. So,
Okay, so I thought we'd do a little bit of range of motion exercises, but
Great.
you're going to put on some music for us.
I am not going to put on music. Yes.
Yeah, so Stephanie, you hold our
All right, yes.
our camera there. Okay, so we're going to do some trapezius.
Okay.
And we're going to do some exercise for the trapezius, also for the multifidus, the levator scapula, the splenius cervicis, the infraspinatus, longus coli, and the suprainfrahymoids. Okay, so we're going to put a little music on. So let's do ear to the shoulder, middle, ear to the shoulder, middle, ear to the shoulder, middle, ear to the shoulder, middle. Then turn to the right, or your left, or right.
My left. Okay, we'll do it opposite here.
No, when I'm on the street where you live. Okay, chin to your chest. In the heart of town. Okay, shoulders up, shoulders down, shoulders forward, your thumbs all the way in, and thumbs all the way out. Shoulders up, down, and head and everything forward, and the thumbs and everything back. Good. And shoulders up, and down, and everything forward, and back. Now let's just do one arm at a time. So let's do your left, and in, and out, and in, and out, and in, and out. Other side, and in, and out. Thumb way out, thumb way in. Both together. Okay, let's do the range of motion exercise. Let's go ahead and touch your, then come like this, then come like that. And go, same arm, here, go, and then come across. And, okay, change over to the other arm. Touch your shoulder blade, across. And then you can go ahead and do your arm. And then go ahead the same side. And across. And across to the corner of your mouth. Okay, great. So let's do the multiplicity. For that, we're gonna just really, really turn and really look over your shoulder. And we're gonna again look way over our shoulder and hold it, breathe and relax. And the other way. So that's for all of our head turning muscles. We're holding it. So what I do like throughout the day to make all those heads, so the splenius, the trapezius, the vater, and also the multiplicities, throughout the day, I just go ahead and really look around. So I hold the shoulders in neutral, and then I look way around and look all at different things. You know, so I try to really make sure that I look around throughout the day, look at buildings, corners of the room, and if I'm at church, I look at everything, look at the ceiling. So you really got to really move them. Now, what about for our infrahyoids? So for this, let's go ahead and let's just do light pincing while we're moving. Now, what are some special tricks though? Then we have a special, what do we call it, Justin?
Silver bullets?
The silver bullet. Okay, we have the silver bullet. Okay, so we had an underlying perpetuating factor, and in your case, remember, we saw something really interesting. So something that was holding her neck forward was her abdominals. So
explain this again.
So
holding the neck forward?
Yeah, so here she was going like, so the abdominals are short. So it's making her head go forward like this. So her abdominals are short, so the head's going forward. So one way of correcting it is in the way you know what's happening is you get your finger right on the abdominal, and then you lean back and you go, whoa, the abdominals are tight. You can feel it. So you can see right there. So one thing that can cause neck pain would be short abdominals.
Okay, so silver bullet of this week is rarely ever treated trigger points in the abdominal wall muscles, especially on the stretch, can cause anterior head carriage, shoulders rolling forward, all sorts of postural distortions in the upper half of the body, right?
Yes, and cross syndrome, which we also found on her. So her abdominals and her pecs were short, so we could treat the pecs.
Oh yeah.
Her stretch. Whoa, whoa.
I forgot about that old upper cross syndrome.
Whoa. So we're treating her underlying perpetuating factors. So short pecs and short abdominals. So we'll go ahead and treat them.
Yep, and it's a pincer contact you're using for the
That's
abdominals, right?
I did do that, yeah.
Yeah.
And so great, you won't believe how great it is. It's so great.
And how sore it can be too.
Oh,
yes.
The first time she did it to me, I screamed.
She did scream.
Yeah.
She was like so surprised.
I was okay this time.
So I went like this, and like she went, what'd you say?
I leaned back, I screamed.
She was like, oh my gosh, she was so, but that's one thing that really can cause you to have really bad neck.
So now, if you've never treated, I'm just going to say this, and Sharon never minds disagreeing with me, but if you've never treated, I think she'll agree, but if you've never treated something before on an individual, and you've never had it treated on yourself, the best thing to do is to go home and do it to yourself. Practice it, get used to it. If you've never had someone work on your abdomen,
right,
and you've never worked on anyone else's, well then start with your own and see what it feels like, so that you know how it's going to be for someone else that you're working on. But why don't you just go on the next 5 massages you give and play around with the abdominals on yourself, work all of them, review. There's the internal abdominal oblique, the external abdominal oblique, there's the rectus abdominis, then there's just all the different fascia that's in there holding the abdominals together.
Better.
And why don't you just work on that on yourself, and then the next 5 massages or massage appointments or trigger point therapy appointments you have, just palpate them on some of the patients and just see what you find. If you're bored in practice, then you're probably not.
Okay, then one more time.
You're not being curious enough, because there's plenty enough interesting things going on every day, and every person comes into the office. Wow, that's a significant improvement.
Yeah.
Thanks. Okay, so we found a few improvements on you. So good. So
I still see the character flaw. I don't know.
Which one is that? Let's not discuss it. Okay.
The one I keep focusing on.